Right, let's just jump straight into it. Today, we're tackling a massive clinical paradox. You know the one, patients coming in with severely debilitating chronic dizziness, but when you examine them in the office, totally, perfectly normal. We're talking about visual-induced dizziness, or VID, which is honestly one of the most under-recognized dizziness presentations in primary care and hospital settings. We're going to break down exactly why it keeps getting missed, and more importantly, how you can spot it right away.
So, picture this exact scenario. You've got a patient sitting across from you. They've been dealing with daily dizziness for 6 whole months. They've had routine blood work, maybe even some expensive imaging, and absolutely nothing. Everything comes back totally unrevealing. You do your bedside neurological and vestibular exams, and again, completely normal. Well, it begs the question, is the diagnosis actually missing, or are we just asking the wrong questions? When a patient's functional impact is this dramatic, but their physical exam is totally unremarkable, we really need a paradigm shift.
Here is our roadmap for this explainer. First, the diagnosis the examination misses, then the mechanism of visual mismatch, followed by the conditions dominating visual dizziness. After that, we'll cover the 5-feature visual trigger inventory, the severe functional patient impact, and wrap up with key takeaways and next steps.
Section 1. The diagnosis examination misses. Why the clinic fails.
Think about your typical clinic room for a second. It's quiet, it's static, the lighting is usually pretty consistent, and honestly, nothing is really moving around. Now compare that to the overwhelming chaos of the real world. Think about walking down a busy supermarket aisle with those towering shelves and high-contrast packaging, or just rapidly scrolling through a smartphone. See, patients with visual-induced dizziness are made dizzy simply by looking. That static, unstimulating clinic room entirely lacks the dynamic visual triggers of the real world. So, because those triggers are completely absent during your assessment, of course the examination is going to be normal. The diagnosis literally doesn't live in the physical exam. It lives 100% in the patient's history.
And to put into perspective just how crucial this is, visual-induced dizziness is reported by 20 to 30% of patients in tertiary dizziness clinics. Think about that. That is a massive chunk of people. It's an incredibly critical misdiagnosis. In fact, it persists in roughly 1/3 of patients in the months following an acute peripheral vestibulopathy or concussion. So this isn't some rare 1 in a million zebra. It's a very sensitive cross-sectional marker of an underlying vestibular vulnerability, and it accounts for a huge proportion of the chronic dizziness you're already seeing in general practice.
Section 2. The mechanism of visual mismatch. What's happening in the brain? Okay, so what's actually happening under the hood? Well, human spatial orientation normally relies on 3 main sensory streams: visual, vestibular, and somasensory. And these all integrate in a brain network centered right on the parieto-insular vestibular cortex, or PIVC. But when one of those streams becomes unreliable, let's say right after a vestibular insult, the brain has to compensate, right? So it reweights the remaining streams. The problem is, in a substantial minority of patients, this sensory reweighting becomes totally maladaptive. When these folks encounter rapid optic flow or intense repetitive geometry, it generates this sustained mismatch between the visual stream that the brain is now overweighting and the vestibular stream it's underweighting. And the conscious feeling of that exact mismatch, that's the dizziness on looking.
We call this state visual dependence. It's essentially a state where the brain becomes persistently and maladaptively over-reliant on visual input just to figure out spatial orientation. And this physiological state is exactly what locks in that visual vestibular mismatch. The brain is basically just trusting the eyes way too much. So the second the eyes get confused by a busy pattern or a fast-scrolling phone screen, the entire orientation system basically crashes.
Section 3. Conditions dominating visual dizziness. The usual suspects.
Now, recognizing these clinical patterns is a real game changer because it allows you to assign a confident working diagnosis right off the bat at the very first visit. First up, we've got PPPD, or persistent postural perceptual dizziness. This one features daily, non-spinning dizziness lasting 3 months or more, and it's classically worse when the patient is upright or exposed to complex visual stimuli. Next is vestibular migraine. This presents as episodic vertigo with migrainous features, but interestingly, interictal visual-induced dizziness, meaning between the major attacks, is super common here. Then there's mal-de-débarquement syndrome, or MDS, which is that persistent rocking or swaying feeling after travel, like a cruise, and it classically actually improves with passive motion. And finally, post-vestibular insult. This is VID that emerges in the weeks following a discrete event like vestibular neuritis, or even treated BPPV, where the visual dependence just stubbornly persists long after the initial physical insult has healed. If you're a busy primary care practitioner, keep these 2 incredibly high-yield practical rules in your back pocket to help distinguish the most common underlying causes. Rule 1. Dizziness that is strictly episodic, with discrete attacks lasting minutes to hours, is migraine until proven otherwise. Rule 2. Dizziness that is daily and constant is PPPD until proven otherwise. Seriously, PPPD and vestibular migraine together make up the vast majority of chronic VID cases you're going to see in primary care.
Section 4. 5-feature visual trigger inventory, the diagnostic clues.
Since we know the diagnosis is in the history, you absolutely need to explicitly ask your patients about these 5 specific environments. Number 1, supermarket aisles. This is the classic optic flow trigger, thanks to tall shelving and harsh fluorescent lighting. Number 2, crowds and markets. Basically, environments with many independent moving objects that cause motion conflict in the brain. Number 3, scrolling and screens. Think phone scrolling, fast-paced videos, or visually busy spreadsheets. Number 4, patterned floors and carpets. Stripes or strong geometric repetition can easily be mistaken by the brain for self-motion. And finally, number 5, highway or passenger driving. This provides continuous peripheral optic flow but without any active steering input from the patient to help ground them. If your patient hits on 3 or more of these triggers, that strongly suggests visual-induced dizziness.
And I want to quickly clarify a really tricky patient vignette you are definitely going to encounter. I call it the pseudo-constant pattern. Patients will sit down in your office and swear up and down that their dizziness is constant. But in reality, it only feels constant to them because our modern world is just an endless, exhausting stream of visual triggers. They glance at their phone, dizzy. They walk into the kitchen over a busy patterned rug, dizzy. They pop into the grocery store, dizzy. So you have to dig a little and ask, is the dizziness actually being brought on by these busy visual environments, or is it strictly tied to their own head movement? Parsing that out is absolutely crucial for separating VID from other vestibular issues.
Section 5. Severe functional patient impact, the hidden cost.
Because this vital connection gets missed so often, patients frequently don't get answers for months. They bounce around, seeing multiple clinicians, and just accumulating giant stacks of completely normal test results. And you can imagine the frustration, right? The huge mismatch between their very real, dramatic functional impairment and your completely unremarkable clinical examination often leads to them being reassured way too prematurely, or worse, referred out for repeated, totally unnecessary structural investigations.
Make no mistake, the lifestyle impacts of this condition are incredibly severe. These folks start avoiding shops, social venues, escalators, the whole shebang. They struggle immensely with any kind of screen-based work, which, let's face it, in today's economy often means they literally have to reduce their hours or leave paid employment entirely. And please, I strongly urge you to always document their driving status. Because highway driving and that intense peripheral optic flow are major triggers, a lot of patients quietly just stop driving. And they usually won't volunteer that huge piece of information unless you specifically ask them about it.
Section 6. Key takeaways and next steps.
All right, let's drive the core thesis of this explainer home one last time. Visual-induced dizziness is a highly sensitive marker of an underlying vestibular vulnerability. Your clinical exam is totally normal simply because the visual triggers of the chaotic real world are completely absent in your quiet exam room. So remember, a normal physical exam does not mean there's no pathology. The diagnosis lives entirely in the history. Use that 5-feature inventory we talked about. 3 or more positive features is a massive red flag that predicts VID. Simple reassurance alone is rarely going to cut it. These patients desperately need targeted assessment. And that sets us up perfectly for the next step. In the second explainer of this series, we're going to get our hands dirty and dive way deeper into the actual mechanics and the bedside workup. We'll unpack visual vestibular mismatch in greater detail. I'll show you 3 specific bedside provocation maneuvers you can do right away without any fancy equipment, and we'll introduce the visual vertigo analog scale, a super practical baseline measurement to actually track your patient's recovery. You definitely won't want to miss that one.
Thank you so much for joining me for this explainer. To explore more topics on dizziness, vertigo, and imbalance, and to access some really incredible clinician and patient materials, be sure to head over to AustralianDizzinessClinics.com. Please subscribe, leave a rating, and until next time, are you absolutely sure you're asking your dizzy patients the right questions?